already we need to test multiple biomarkers in frontline, including MSI, PD-L1, HER2, and Claudin 18.2. And this kind of biomarker should be also important in later line, more and more in the near future. So we have a TDXT as a HER2 ADC as a standard of care, particularly for HER2 positive disease. So to test the HER2 positive status after a first-line chemo trust or upcoming chemo-zanidatamab combination should be still important. And we are waiting for additional phase 3 study or other study using Claudin-targeted agent like ADC. And it also based on Claudin status after zolbetuximab. And sometimes we see the reduced or loss of HER2 status and increased Claudin expression in same patient. So this kind of temporal heterogeneity of the biomarkers should be very important in gastric cancer, even in later line setting. So that means before considering sequence of new types of treatment, always we need to test biomarker just before a new treatment. But always biomarker is not always feasible. For example, if patient has a distant metastasis, so we need to have a multidisciplinary team management to consider needle biopsy from distant metastasis or sometimes surgical approach like a laparoscopy. And for future, maybe we have a more sophisticated technique like imaging technology, because HER2 Claudin is a protein, so we can use such kind of imaging like a PET scan. So eventually it may be more convenient and less invasive for patients. I believe such technology advance is also very important to consider sequence of treatment in the near future.